Okay, let's get started. Very pleased to introduce our two speakers today. First, Naveen Kukrecha, hopefully I said that right. He just a recent recruit, and he earned his medical degree from the University of Missouri, then did his anesthesia residency training at the SUNY Downstate Medical Center in New York. This was followed by a critical care fellowship at the University of Rochester. After that, he worked at different places, including the University of Texas in Houston, and now he's a critical care ICU attending with us, works at the STICU, burn ICU, and is also very excited to join the liver transplant team and has a high interest in quality improvement. And our second speaker, you all know him very well, Tony Oliva. He earned his MD and PhD here at the University of Colorado, did his residency training in our department, and then did training in neuromonitoring. And after that, he became a dedicated and admired teacher, and he got so good at teaching that he finally became the program director of our residency program. So, and today they have an exciting case about a vision loss, and I think Tony will give us some up-to-date insight on how to deal with these patients. And then I think we have an announcement from Claudia. Thanks.
Can you guys hear me up there? Everybody hear me? Okay. Okay, so today we're going to talk a little bit about a case that happened back in November that ended with a patient that had perioperative vision loss, and this will be a segue into a recent practice advisory that was issued for perioperative vision loss by SNAC. So the patient in question was a 71-year-old male with a history of spinal stenosis of the lumbar spine at multiple levels, degenerative disc disease, scoliosis, and he came in with a lower extremity radiculopathy and was going for an L4 to S1 for anastomy and decompression under general. And as you can see, he was not obese at all, and had no contributory allergies. He had a history of well-controlled GERD, well-controlled hypertension, well-controlled hypothyroidism, a DVT with results in PE a long time ago, many years ago, was not on anticoagulation for this, a history of well-controlled gout, prediabetes, and a squamous cell of the left tonsil for which he had undergone radiation therapy back in 2013, and actually a vocal cord medialization in 2018, and was still being treated to this day for that problem. He had a past surgical history of a distal pancreatectomy and splenectomy back in 1967 when he had a motor vehicle accident. Subsequently ended up with an incisional hernia and a bowel obstruction which required repair. And then he had a variety of small procedures, a few of which were done under general anesthesia, knee surgery, colonoscopy, rotator cuff repair, so on and so forth. And none of the anesthetics in the past. He had no problems with anesthesia in the past. He had a non-contributory social history. He was a former smoker, 8 pack years, quit 42 years ago, otherwise non-contributory social history. He did have a contributory family history. His mother did have some eye problems of macular degeneration and vision loss, but otherwise a non-contributory family history. He was on a baby aspirin a day and gabapentin, and those were really his only home medications. So when we put him to sleep, it was a relatively uneventful induction. It was a straightforward first-time airway. We actually had an anesthesia assistant in training who did the case, the induction. He subsequently graduated and now works with us. And really, there was nothing to be said about the induction. It really didn't stand out. There were not multiple attempts, and his eyes were taped as soon as he was put to sleep. He was position prone, as most of our patients having spine surgery are, and he was in Superman position with his arms out in front of him, and his eyes were taped with tegaderms, and he was in a prone view pillow and we could see his eyes very well. And we had 3 sets of people that actually examined his eyes to make sure there were no pressure on them, and there was not. He was not. He had a very slender, conducive figure whenever we positioned him. And so this is the anesthetic record, and I apologize. We had to kind of cut out some of the portions of the anesthetic record just to be able to emphasize the vital signs. So you can't actually see the vent settings, but he was on 6 cc's per kilo with a PEEP of 5 and an FiO2 of 40%, and his eyes were being checked routinely. You can see here on induction, he has a brief moment of hypotension. This is induction here. And then after induction, he settles out. And while we're waiting to position him, he becomes hypotensive again. This is about 3 minutes in duration. It's treated with fluids and vasopressors successfully, and he recovers. And that really remains that way for the rest of the case. He was induced with fentanyl, propofol, lidocaine, rocuronium, and then maintained on sevoflurane with fentanyl boluses, and was on a low-dose phenylephrine drip throughout the case. And the remainder of the case was really train tracks. Nothing really eventful to say. There was not a lot of blood loss, and the total duration of the case was about 4 hours. He got some Dilaudid, Decadron, and Zofran for postoperative pain and postoperative nausea prophylaxis respectively. And he did not get a lot of crystalloid. He got 2 liters total for 4 hours, and his total blood loss was 200 mLs. And he made adequate urine throughout the case. At the end of the case, he was extubated uneventfully and brought to PACView. He was following commands. And at that time, we never really heard anything about ocular injuries. And it remained that way for pretty much the entire hospitalization. He was sent, the procedure itself was done on November 30th, and he was sent home on December 1st with no mention of ocular deficits between the time of discharge and the time of surgery. And then at the end of that month, there's a phone call in the chart stating that he had visual deficits consisting of a strobe effect that was worse in the dark out of the left eye only. And for whatever reason, they noted that the symptoms were noted to have started on the 29th, so about a month after surgery. So that prompted him being sent to an ophthalmologist. And at that time, he noted that the symptoms did not actually start on the 29th, that they actually started once he came out of surgery. And that's when he noted intermittent flashing strobe light effect out of the left eye on the temporal aspect only. There were no right eye concerns, and there were no floaters. And at that time, he denied headache or loss of visual acuity. And between the time of surgery and the time that he presented to clinic, he denied any form of trauma. So when he was evaluated by the ophthalmologist, they did a 350 scleral depressed exam, and they noted that there were no holes in the retina, but they did notice that he had bilateral posterior vitreous detachments. And at the time, I'm not an ophthalmologist, and I was not up to date on my ophthalmic pathology. So I had to go back and look at what this meant, but I assumed that this probably had something to do with what we did to him, putting him to sleep, and that it's a known complication after spine surgery, especially in the prone position, prolonged time in the prone position, that you can have visual field or visual acuity loss. And just as a coincidental finding, he was also noted to have cataracts of both of his eyes. So I had to go back and actually review what actually posterior vitreous detachment meant. And so the posterior vitreous is a clear gel made of hyaluronic acid and collagen fibrils that over time, over the course of your life, it can slowly liquefy. And I'll actually show you guys a picture for those of you that need a refresher. I certainly did. The big middle chamber, the pink chamber that you can see Up there, that's your vitreous chamber, and it's filled with the vitreous humor that's got the clear gel in it. And it peels off the retina on the posterior aspect over here. It forms these little pockets. And that over time can lead to fulminant retinal detachment. And if that's left that way for a long enough period of time, it can result in fulminant vision loss. 75% of the people affected are over the age of 65. It tends to affect females more than males, and it likes to present with, it can have a myriad of symptoms, one of which is flashes of light, which is actually what our patient had. You can also have a sudden dramatic increase in floaters, and if it's accompanied with vitreous hemorrhage, you can have one large floater that has a mobile cobway or housefly appearance. These pockets of liquid can break through the posterior surface of the vitreous face, but of note, these don't occur within an instant. They occur over time. Normally, the most common presentation is that it starts and progresses over 1 week, but it can last, the presentation can take up to 12 weeks from start to peak of symptoms. And as I said before, it can lead to retinal detachment, which can progress to vision loss. And if retinal detachment occurs, clearly they need some form of intervention. This is a picture of somebody who actually has a fulminant retinal detachment, and as you can, and as you can see, the vitreous body is peeled off. The entire posterior portion is peeled off the back of the retina. Posterior vitreous detachment, though, would actually only have a pocket up to here. So this is anytime I have a patient that has any type of ophthalmic complaint, being that I know that eye injuries are not my forte, I get ophthalmology involved, unless it's your garden variety corneal abrasion. The ophthalmologist will do ophthalmoscopy, fundoscopy, and they'll dilate the eye. And in this case, what they're looking for, if you have a posterior vitreous detachment, you may see something called a Weiss ring, which I'll show you a picture of in just a moment. You can see vitreous debris. And in the anterior chamber, you can see something, or if there is accompanying vitreous hemorrhage, you can see tobacco dust in the anterior chamber. It's called tobacco dust. It's like red little flecks that you'll see in just a moment. So this is a picture of somebody who actually has a Weiss ring. If you look closely, you can see this ring in the dead center of the eye. It's this translucent circular object right over the middle. That's actually a Weiss ring. But if you're not looking for it and you don't know what you're actually looking for, it'd be pretty easy to miss. It's not that obvious. This is a picture of somebody who actually has vitreous debris. You can note the little white spots throughout the entire vitreous chamber. And this is a picture of somebody who has the tobacco dust in the anterior chamber. If you look at the little red flecks, that's what you see whenever there's accompanying vitreous hemorrhage. And for this patient, thankfully there were no retinal breaks or tears. If there are, then they need surgery for retinal detachment. In this patient's case, most of the floaters or strobe light effect resolve spontaneously over the course of a few months. But if they're disabling enough, then they would undergo vitrectomy. So once we heard about this case, we sent a message out to our QI department, and they contacted the ophthalmologist that evaluated this patient, and they actually were more of the opinion that this was something, it was more coincidence rather than, it was more correlation than causation, that he had just had anesthesia and surgery, that this had been something brewing and was not actually the result of his anesthetic care. But certainly this is a good segue into talking about the new practice advisory of perioperative vision loss, as this was a case of perioperative vision loss technically.
Okay, so given that this particular case wasn't the classic vision loss type case that you get after spine surgery, we're going to talk a little bit about more common types of vision loss and the newest update for practice advisory that just came out in January. So I don't have any disclosures to make. So the objectives, we're going to do a pre-test. So if all of you would take out your phone, this is the one time that you should take out your phone for presentations, right? Go to your text area and text 37607. And you need to type Tony Oliva 389 into a message and send it. We're going to do poll everywhere. You should get a reply response saying that the poll is open and that it's waiting for a question if it's successful. We'll review the latest practice advisory related to spine surgery and post or perioperative vision loss, and then we'll do a post-test. So this is to make sure that everything's working. So if you've done the text to that number, you should be able to enter in what your role is. So if you're an attending or if you're a resident or a student, say what you are. And this allows actually the people that are outside of this auditorium to participate as well. So if you're at the VA or Denver Health or you're at home, you can also participate. So we got a pretty broad group of people here. Somebody's trying to be funny and say they're the king, huh? All right, so here's our first question. You have, what is the most common cause of perioperative vision loss after spine surgery in the prone position? So it looks like the strong majority is going to be answering B. B is the correct answer for this question here. Ischemic optic neuropathy by itself is going to be the cause of vision loss most often in these spine patients, and it's going to be of the posterior variety, and I'll talk a little bit about the difference between anterior and posterior in just a moment. Central retinal artery occlusion is something that can result in spine surgery, but it can result from other types of surgeries as well, and that type of cause for vision loss is going to be mainly related to pressure on the eye. So when you see that, it's going to be because the eyes were not appropriately monitored. And then cortical blindness is something that, of these options up here, really is the least common. Is going to be really not anything related to the eye itself, but related more to embolic events that are happening within the cortical areas for vision. Which of the following responses are least likely to be associated with posterior ischemic optic neuropathy? So it looks like this one's ending up a little bit more varied. The correct answer here actually is going to be A. So in these patients that have posterior ischemic optic neuropathy, the fundoscopic exam is normal. That's one thing that differentiates it from the anterior version. When you have an anterior ION, you're actually going to have some fundoscopic changes that take place. It is going to be painless. That's true for most of these issues that happen with vision loss perioperatively. They don't have pain. That's one thing that differentiates it from corneal abrasions, is that corneal abrasions do have pain associated with it. And at least for posterior ION, they do have impaired color vision. So that's something that is notable for those patients. If they don't have complete loss, they can have vision loss really of color vision first. So for the purposes of posterior ION, most cases actually are going to be of bilateral vision loss, and nobody really understands why it's bilateral. Prolonged duration of surgery in the prone position is associated with increased risk of perioperative vision loss. Which of the following options correctly identifies the definition of prolonged surgery? This is showing a majority of people think that it's greater than 4.5 hours. That's actually incorrect. The correct answer here is C. So 6.5 hours is what's considered to be the threshold of a prolonged procedure. And the interesting thing about the 6.5 hours, if you go back and look within the literature, this number came about due to expert opinion. There's really no data that supports that this number means a whole lot. But that this is the average of what most experts would say a prolonged surgery is. One interesting thing about this 6.5 hour mark, though, is that there's a registry that the ASA put out, or a paper that they put out based on a registry of patients that had post-op vision loss, and 94% of those patients, it was a pretty small group anyway, but 94% of them had procedures that were longer than this 6.5 hour range. So there's a little bit of evidence there that longer than 6.5 hours can be problematic. Substantial blood loss during spine surgery in the prone position is associated with an increased risk for perioperative vision loss. Which of the following responses defines substantial blood loss? In this one, it looks like we have a majority of people saying that greater than 50% of EBL is the right answer, and that is correct. Mainly the research that you see in the advisory that we'll talk about, the actual number that they say is 44% of estimated blood volume, so rounding up, it's around 50%. So for most people, that's going to be about 2 liters of blood loss, 2.5 liters of blood loss. So that's a significant amount of blood loss. I think we can all agree that that's substantial. All right, so this is a little bit of anatomy of that optic nerve so that you can start to appreciate some of the differences between the types. So, excuse me, you have within the cranium, so this is going to be within the orbit, within the cranium you have a branch off the internal carotid, which is your hypophyseal artery. And that hypophyseal artery is going to be given blood supply to that optic nerve really within the cranium and then just as it's exiting out of the cranium. Then you have a branch off the internal carotid, which is your ophthalmic artery, and that gives rise to your posterior ciliary artery. And those branches are going to be giving blood supply to the nerve really at the junction of the eye and then going, and then going posterior. And so what ends up happening is there's a watershed area within the nerve itself where you don't get great blood supply from the hypophyseal, and you don't get great blood supply from your posterior ciliary. And so this area here has some collateral flow, but it's at risk of having ischemic events. So this is where your posterior ischemic optic neuropathy is going to take place. Your anterior is going to be really at the area of the optic disc, and that's from issues related to your posterior ciliary artery. And then you have your central retinal artery, which goes through the center part of your nerve going to the optic disc. So for this particular advisory that was done, these are the organizations that were involved. And this advisory is actually an update. So the last time they did the advisory was in 2012, and prior to that it was 2006. So they've been doing it about every 6-7 years. And in 2012, excuse me, let me go back to, this thing's very touchy. These top 4 organizations were involved in the last iteration of the advisory. So this organization on the bottom was new to this particular advisory. And with the advisory that came out in 2012, there were about 47 studies that were included in that advisory. And since that time, with this new advisory in 2019, they added about 27 new studies. And many of the studies, as I'll tell you in a little bit, really aren't studies per se. Many of them are case reports or case series. So there's not a lot of great literature to support these things. The other thing that I'll mention is that there was a task force from really these different organizations, 16 members on this task force. They were responsible for doing the surveys. They were responsible for getting the expert opinion and figuring out who these experts were going to be. And the 16-person task force, about 6 of them were anesthesiologists. 2 of them were neurosurgeons. 2 of them were spine orthosurgeons. They had a couple of other neuro-ophthalmology folks on that task force, so it was a pretty varied group of people. And the important thing to remember about advisories is that advisories are not meant to be requirements. They're not meant to be guidelines. They're simply just expert opinion and what data is available for that particular issue. So typically for things that are rare occurring things, much like post-op vision loss for spine surgery, there's not enough cases for them to really give you guidelines, give you recommendations. These are just updates on the best available evidence and opinion. So there's really only Category B support for this set of advisory guidelines or advisory statements. So observational studies really are the best types of studies that they have, but the majority of the evidence within the advisory is via case reports. So for preoperative evaluation, there's really a couple of pieces for literature support. There's some patient risk factors, and those patient risk factors really are going to be things that you might expect, so anemia and some potential for vascular disease with CAD and PVD. Obesity is a risk factor, age, and male sex. These 3 components here actually have been teased apart within the last 5 years. So in the 2012 advisory, those were not present in their advisory. You have no data to support a pre-op eye exam. That's obviously, it's such a rare occurrence that that's going to be wasteful in terms of spending. And interestingly, this is also new since 2012 that the majority of patients prefer to be informed of the risk of vision loss. This is something that I think in terms of practice by and large our faculty and I think even our residents, we often don't talk to our patients about vision loss, but they want to know that information. So there's a study that came out that showed about 86% of those patients actually want to know that that's a risk for them for that procedure. So what are the advisory recommendations for preoperative evaluation? So first, you got to do an H&P. You got to inform the patients that certain medical conditions may increase their risk of POVL. So are they having vascular disease? Do they already have risk factors related to comorbidities for vision loss? You want to inform patients that are having prolonged procedures, the risk of substantial blood loss, or both. So we do a lot of these cases within our institution at UCH. So these are conversations that you should be having with your patients. And then for the people that are considered low risk, right, those are going to be people that are having short procedures, not a lot of blood loss. These are procedures on patients that are non-obese, younger. Those patients, it's a case-by-case basis whether to inform them of this risk. How about intraoperative literature findings? So there's equivocal findings on whether risk of ION increases with intraoperative hypotension. In 2012, there actually was a lot of comment about deliberate hypotension. Deliberate hypotension has been done for a variety of procedures, mainly orthopedic, but also spine procedures, to minimize blood loss. And so deliberate hypotension at that time in 2012, and currently there's really not enough data to support that hypotension by itself actually increases somebody's risk for having vision issues post-op. There's increased risk with substantial blood loss and prolonged procedures or both. That is one thing that has been persistent since 2012. That's a continued recommendation or finding. There's reduced risk with higher colloid as a percentage of total non-blood fluid replacement. So in some of these reviews of people that had vision loss, many of them that had vision loss really had colloid-only fluid replacement. And so there's this feeling that having colloid as a component of your fluid replacement actually helps prevent or decreases the risk of having vision changes. And there's insufficient or equivocal findings on the impact of vasopressor use in ION. So patients that are having vasopressor use, particularly high doses, the thought was that they need high requirements of vasopressor use, that those patients are at high risk. That turns out to not be true. And so the recommendation really is to use vasopressors as needed when necessary. And then lastly, use of the Wilson frame is significantly associated with ION. And many of our trainees and many of our students have never seen this frame or see it infrequently. It's not used very much anymore, but this is what it looks like. Most of the time you have this component here, which is separate from the bed. You just lay it on a regular OR bed, and the patient's hips are going to be over on this side, and they lay over this with their face over here. And you can see from that, the way that this is shaped, that you have a patient oftentimes that has their head lower than their heart for the duration of the procedure. And that's something that in 2012 they said, well, you really shouldn't have the head lower than the body for these procedures because that increases the risk. That really has not been borne out in data either. But the idea is, if you can imagine somebody, if you've used this frame and you've tried to position an obese patient on this frame, you realize very quickly that they don't position very well. Their chest is, and belly is going to be up on top here, so they really do have a head down position, a lot of intra-abdominal pressure onto their abdomen as well. So this frame by itself is a risk factor for post-op vision loss. So how about managing these patients? What are the recommendations? So monitor blood pressure. We're obviously going to do that, and you want to maintain it in an appropriate range for the patient, whether they're hypertensive or otherwise. You want to monitor hemoglobin when indicated and transfuse blood as needed. There's really no data that supports any particular number for hemoglobin. So when to transfuse, there's really no data with respect to eye issues on what that number needs to be. Administer crystalloids and colloids alone or in combination to maintain intravascular volume. Give vasopressors when necessary. Position the head in a neutral position or higher than the rest of the body when possible. And again, this has no data behind it either. And if this really were an issue, all of these cases that we do for robotic procedures with the head down, steep Trendelenburg, these patients would be having more vision issues if that really was the main cause. And then you obviously want to avoid direct pressure on the eye and check the eyes periodically. So post-op, the literature findings, really there's only case reports that exist for the treatment of ION, and by and large, the treatments don't work. There's a case report that shows that somebody had some improvement in their vision with bumping their blood pressure up in the post-operative period, but there have been others that showed that there was no effect and no benefit. And so there's no other evidence for antiplatelet agents, steroids, or intraocular pressure-lowering agents to help with post-op vision loss. This is unfortunately often going to be a permanent thing for those patients. There can be some recovery, but often there's not. The recommendations, well, if you have a patient that's high risk, you want to try to assess their vision when they become alert. That can be in the PACU, that can be up on the floor, but the idea is that you want to make sure that you assess that sometime as soon as they're alert. If you have a concern, obtain an ophthalmology consultation. That's something that was done in our last case, and so you want to make sure that you don't mess around with that potential issue, and you want to get an expert's opinion. Imaging, MRI or CT can be used, but it turns out that many of these cases that did have vision loss, their findings on imaging are negative. They don't see anything that is contributory, but that's one of the things you want to rule out, particularly if you're worried about cortical blindness, because that's an embolic event usually, so they might have some ischemia in other areas that could show up on imaging. And then additional management may include optimizing hemoglobin, hemodynamic status, and arterial oxygenation. Again, that part has really no data behind it either. All right, so here's our post-test. So these are more clinical vignettes. 68-year-old man with hypertension, diabetes, presents for multi-level lumbar spinal fusion. Which of the following types of perioperative vision loss is most likely to occur as a result of direct pressure on the eye in the prone position? So it looks like the time change affected some people. We got too many tired people here. So I said that when you have direct pressure on the eye, you have central retinal artery occlusion, right? So that's going to be the answer for this particular question. Your ION versions of vision loss are going to be really without any etiology, right? So there's really no cause that people can figure out. It seems to be sporadic. With this C response here, that actually is a known entity. You know that the patient had pressure on their eyes. That's what causes the issue. And then we know that embolic disease causes cortical blindness. A 74-year-old obese man with CAD and diabetes undergoes laminectomy infusion of T10 to L5. Following surgery, the patient is found to have significant vision loss. Which of the following factors is most likely to have increased his risk for post-op vision loss? So I'm going to stop it right there. So the majority say obesity. Obesity is the correct answer here. Age is something that also is involved in the newer advisory as far as a risk factor, but obesity turns out to be more corollary to higher risk. So obesity is the best answer here. Last one, a 76-year-old, 65-kilo man is undergoing a posterior lumbar spinal decompression infusion. Which of the following factors most increases his risk for post-op vision loss? So it looks like here everybody was listening on this one. I should say most people were listening. So male sex, the fact that this is a man, is his biggest risk factor here. So the Jackson table actually is a better table to use. Again, the Wilson frame is the one that we're concerned about. This person's not obese, so that's not going to be a problem. And then we talked about how vasopressors don't impact the issues related to vision loss. Any questions about the case, the brief review about the advisory? Yeah.
I'm curious, the surveys that they did with the past together the recommendation, there's a question about whether or not people would like to hear about the risk of visual loss. They haven't asked them when they'd like to hear about that. Like 2 weeks before surgery, when they talk to the surgeon, or 15 minutes before they go into the operating room.
So the question is, for those of you outside of the auditorium, the question is if the information about patients wanting to know about their risk of vision loss with these surgeries, when do they want to know? Do they want to know right the day of surgery? Do they want to know at the time that they are deemed to need surgery or would like to have surgery? That particular survey, I don't know what the timing was. My understanding, though, was that it was at the time of them being explained the surgery and the risks associated with surgery. So that seems to imply that it would be really in the hands of the surgeons to be talking to them about that. Joy?
I would just like to echo that. I know both on a local and a national level, there's been discussion about whether the surgeon should be consenting the patient to this aspect or the anesthesiologist. I think the anesthesiologist is particularly proactive in saying, we need to be discussing this, we're not discussing it. And my impression was the surgeons came along a little more slowly to that. But I strongly feel that a patient should know about this well ahead of arriving in the pre-op holding area. Because once your IV's in and you signed all this paperwork, that was not the time for us to be saying, you do know you can be blind, right? Because that's just so unclear to the patient. But I'd also like to know for the people who work in the pre-procedure clinic, because I assume many of these patients will go there, how that's being handled in pre-procedure.
Anybody want to comment from the pre-procedure clinic? Yeah, Angie.
Yeah, so a couple things to add first. There's a Anethesia Patient Safety Foundation has a couple videos on this. They really recommend that it's part of the surgical consent, but in the absence of it being discussed with the surgical consent, that it is appropriate and
just for the people that are outside of the auditorium listening in, the comment was about how the Patient Safety Foundation has videos on perioperative vision loss for these patients that you can reference them to so that they can watch these videos and become educated about them. And that our preoperative clinic does have these discussions with patients. Any other questions?
I'd like to comment on a great presentation, but one of the things that really is a glaring part of this, really comes to light in this presentation, that there is still a heck of a lot that we don't know about this condition. The incidence is so sporadic. It happens to 17-year-old kids with collision surgery, 85-year-old people who want spine surgery, and people who want breast surgery, and prostate surgery, and cardiac surgery. And there's almost no way to really predict how this is going to happen. And as Tony mentioned, all treatments are woefully inadequate to happen at all. So there are probably some moral factors that are involved in this, as actually the one may have keeping up with that. But there's just so much we don't know about this.
Any other comments? Yeah, Leslie.
I actually have a question. So most people, when you do ask the question, how much I have one person who has a increased higher loss, and it's crazy of becoming more loss. And I have absolutely no idea what I'm saying, but that's how it feels.
Yeah, the literature on the high end says maybe 2 in 1,000, but I think that's probably really not true. On the low end, it's probably more like 2 in 10,000 or 2 in 20,000. So, yeah, it's a very rare occurrence. Any other questions? All right, Claudia, you want to come down and talk about your last couple of slides?
Good morning. Before we go and start our clinical day, I wanted to remind everybody about the protocol that we have in our institution for placement of the EMG recording tube. Most of you who have been in this institution for a while are familiar with it. We have a lot of new hires, and for them this may be new information. The protocol that we have is a standard of care for all thyroidectomies, parathyroidectomies, and neck dissections when neuromonitoring of the recurrent laryngeal nerve is requested. We also have adopted the same protocol for placement of the exactly same tube for anterior cervical spine surgery when they need neuromonitoring, and also for neurosurgical procedures when we want to monitor cranial nerve pain. The protocol looks like this. It's a laminated card. It has a picture on one side of where to place the tube in relation with the vocal cords. And on the other side, you see instructions and recommendations on what to do, what not to do, how to position the tube, and where to place it, how to tape it, because taping the tube is as important as perfect positioning. These cards are in all anesthetizing locations. I've been working with Nana, our lead tech, to make sure that all anesthetizing locations have the protocol in place. Throughout the years, we have printed more than 300 copies of these protocols, and they tend to disappear. So we got new cards. They are all hanging from your computer monitor in the OR. Please don't remove them from the OR. If you would like a laminated card, I'll be happy to give you one. I'm going to send later today the electronic version of the protocol. If you have any questions about the protocol, if something is not clear or confusing or you just want to go through it, please contact me or contact any of the neuroanesthesiologists. We cover 24/7. One of us is always on call. You can find the person on call for neuromonitoring on the OR schedule, on the PDF. There is a designation as NM1. That's the person who's going to be in charge of coordinating the monitoring for the day. The reason why we implemented this protocol is because of this study that we did in 2014 and 15. You can see that on the the light blue bars are the number of cases. We review cases from 2009 until 2014. And we encourage the use of CMAC, but in 2013 is when we implemented this protocol. All of the steps that are included in the protocol were either based on the international guidelines for monitoring of the recurrent laryngeal nerve, plus the manufacturer recommendation for this particular type of tube. All cases are, the tube is placed with CMAC, even if you think that the patient has a good airway. The orange line represents the number of alerts that we have, and you can see how the number of alerts dropped after we implemented the protocol, training, and CMAC use for all the cases. It dropped from 15% in 2009 down to 1.75%. So what we think is that we got rid of most of the false alerts that were caused by tube malpositioning because we were strict with the protocol. We educated people how to use it, and everybody was intubated with CMAC. At the moment, we are reviewing the data. We are doing analyzing the data of the follow-up study that covers the number of cases, CMAC use, and alerts from 2015, 16, 17, and 18. We are not done analyzing the data, but I can tell you right now that last year we have over 350 cases of titles, paratitles, neck dissection that require neuromonitoring. So it's very important that all of us are aware of the protocol, and please reach out if you have any questions. Thank you.